This PowerPoint will discuss the care of patients with hematologic disorders that involve clotting. Let's start with thrombocytopenia, which is a decreased amount of thrombocytes or platelets. Etiology and pathophysiology, there are several different kinds. Idiopathic thrombocytopenic purpura, or ITP, is idiopathic, which means that they don't know really why it happens. It can happen acutely in children. The chronic version is seen in adults over the age of 60. You'll see it sometimes after an acute viral illness. You see it in people with hepatitis C or HIV infections, and also sometimes during pregnancy. There is a form of drug-induced thrombocytopenia. Drugs that are included here are furosemide, Lasix, certain nonsteroidal anti-inflammatories, certain antibiotics, antidysrhythmics. And then there is also an immune system dysfunction that you get antibodies responsible for platelet destruction. The common denominator here is increased platelet destruction. Now, not platelet production, but destruction. The diagnosis is made when you have a platelet count of lower than 20,000, and you'll also see prolonged bleeding times on the labs. Signs and symptoms that you will see are petechiae, which is the red rash that can be either small red dots, or these red dots can coalesce as you see in the picture. It can be they can be raised or flat, raised being papular, flat being macular. You can have an ecchymosis, which is a bruise. They can bruise very easily, or you can have frank bleeding. Often the bleeding from the mouth is bleeding of the gums. You can have nosebleeds, bleeding in the GI tract. You may not notice as frank bleeding. You may just have black tarry stools. You may need to be able to have an order for fecal occult blood or guaiac that stool to make sure that it is bleeding. And a brain bleed, especially if it's an arterial bleed, can be fatal. Venous bleeds can be fatal too, especially if you have blood that doesn't clot. If you have an acute onset, these symptoms are very sudden. If you have a chronic onset, the symptoms can be insidious, and you may not realize what's going on until the platelet count is dangerously low. For therapy, most types of these resolve spontaneously. But if you need treatment initially, they will look at steroids. Steroids prolong the life of platelets through immunosuppression, because remember, sometimes there are antibodies present against the platelets. Immunoglobulins can help. Vitamin K, remember, is important for clotting. And sometimes chemotherapy drugs are given. And of course, a splenectomy in very severe chronic cases, because the spleen is the primary site of platelet destruction, and you want to keep as many platelets alive for as long as possible. Nursing care associated with thrombocytopenia is pretty much directed toward the prevention of bleeding. So limited needle sticks for either injections or blood draws, close observation for signs of spontaneous bleeding, and then quick intervention following that. Again, really limit those invasive procedures and take care when you are touching someone, moving someone, pulling up someone in bed. Really avoid any activities that might induce bleeding. You also need to educate people and their families to notify the provider of the signs and symptoms of bleedings. So things to teach them to look for are easy bruising, red spots on the skin, blood in the urine, those black tarry stools, bleeding from the nose, gums, an increase in vaginal bleeding, perhaps heavier periods than normal, new onset painful or swollen joints, and a sudden severe headache, which of course would be a symptom of a brain bleed. Sometimes venipunctures or injections cannot be avoided, and sometimes you have to take out IVs or other things that may cause somebody to bleed. So if you've got somebody with a low platelet count, whenever a venipuncture is performed or an injection is administered or something is taken out, pressure over the site must be maintained for at least 10 minutes to prevent continuous oozing. And remember, you never take that dressing off, you always reinforce it. This photo is from your book. It's just an illustration of what someone's hand can look like from thrombocytopenia. Really ecchymotic, discolored, a lot of bleeding in that hand in comparison to the other hand. Hemophilia is a group of hereditary bleeding disorders that result from a severe lack of specific clotting factors. It's genetic, and here's a picture of a genetic analysis here, chromosomal analysis, and it's an X-linked recessive gene, which means that it has to come from the mother and it's recessive, so you could be a carrier, or if you have two recessive genes, you have the disease. Most common is hemophilia A, which is a depletion of factor VIII. That's about 80% of the cases. Hemophilia B is factor IX. They call this Christmas disease, and I should know why, but I don't know why. And that's about 15% of the cases. Von Willebrand's disease is a related bleeding disorder, and that's a really small minority of cases. So most of what you see, if you see it, will be hemophilia A. The pathophysiology is when you don't have these particular clotting factors, you're unable to form a stable fibrin clot after an injury, and so the bleeding times are prolonged. Diagnosis is prolonged bleeding times and low levels of clotting factors. And then treatment, of course, is administration of the clotting factors that the person is missing. The signs and symptoms of hemophilia are, of course, bleeding from an injury or even bleeding spontaneously. You can bleed into your muscles and joints. Hemarthrosis, which we talked about in the assessment video or assessment lecture, is very painful. And repeated episodes of this can cause joint deformity. So this is something that you really want to avoid if at all possible. If you have mild hemophilia, sometimes the first diagnosis may come with a surgical procedure or a trauma. If they start to bleed, however, and you don't know that they have it, they haven't been diagnosed yet, this can certainly become a very serious thing. Moderate hemophilia, people have occasional spontaneous bleeding, and then you get into severe hemophilia when they have frequent spontaneous bleeding. They get hemarthrosis, they can have a brain bleed without any precipitating trauma. They get large, deep sub-Q and IM hematoma and tomas, and any kind of major trauma is certainly life-threatening for these people. And so the treatment for any of these bleeds is, of course, frequent replacement of the clotting factors in blood products. The goal of therapy is to prevent deformity and to stop bleeding during spontaneous bleeding episodes. What clotting factors you give, of course, depends on what type of hemophilia you have. Hemophilia is incurable, but recent treatment advances have improved outcomes, so they can live a normal lifespan. So again, depending on what kind of hemophilia you have, if you have A and it's mild, you can give them DDAVP, which is desmopressin, and that will stimulate the body to produce more clotting factors. There are also factors that are available in freeze-dried powder that can be reconstituted and given IV. They're made of from recombinant DNA, and this is huge because it used to be the only thing you could do is get blood products from a living donor, and that is how so many unfortunate people with hemophilia became HIV positive. With hemophilia B, of course, you've got factor X. There are complications when therapy is started too late, so pay attention to the patient report of any pain, any sign or symptom that their body feels different than it should. These people really become attuned to their body. If indeed someone with hemophilia has to have surgery or undergoes a major trauma, or actually even a minor trauma sometimes, blood products may be needed. The duration of therapy can be 72 hours if it's a minor issue. A major thing sometimes can be up to 14 days of therapy. Sometimes severe cases, or some people with severe cases of hemophilia, can be treated prophylactically with factors if you are in a situation where you know bleeding is going to occur preoperatively or something like that. So the nursing diagnoses that you want to be thinking about here are acute pain for bleeding episodes into joints, risk for bleeding pretty much all the time, knowledge deficit, they need to learn how to take care of themselves, what things to look out for, how to read what their body's telling them, and risk for ineffective health management, and that just kind of goes along with the knowledge deficit. But it's really important that the kids and their families are educated on the disease and how to prevent bleeding. And this happens to kids at a young age, and they can grow up with a lot of stigma and body image issues. And so that's important as well. Nursing management during a bleeding episode includes administering the necessary clotting factors, elevating the injured body part because you want to control the bleeding. Cold packs will help control the swelling. Pain control, big thing. And looking for further bleeding. If you have bleeding into a joint, chances are, or you have bleeding gums or bleeding nose, chances are there's bleeding going on other places. As I mentioned earlier, psychologically support the patient and the family. This is very frightening and difficult, and you're managing this disease all the time. You don't get a day off from this. Also, encouraging genetic counseling for family members if the counseling hasn't occurred previously, so that they understand their carrier status. Safety alert here. As we know, aspirin prevents platelets from aggregating, so aspirin must never be taken by people with hemophilia. It just increases the bleeding problem. They really need to read labels on all of the over-the-counter preparation they take to make sure that they don't contain anything with acetylsalicylic acid. There isn't a lot out there now that does, but still, label reading is important because that could be a total disaster. When you have severe hemarthrosis, there will often be medical management of aspirating the knee, taking the blood out of the knee to prevent further joint deformity. Disseminated intravascular coagulation, or DIC, is something that can be a little hard to understand at first because it seems sort of counterintuitive. So stay with me on this. So what it is it's catastrophic, overwhelming state of accelerated clotting throughout the peripheral vessels. So you have lots and lots of clotting. And then what happens with all that clotting is you use up all your clotting factors, and then you have uncontrollable bleeding. So what you see is the uncontrollable bleeding, and that seems very strange that it's because of clotting, but that's what it is. So you have an acute onset of this with rapid progression of symptoms. It can develop secondarily to another disease process. It often follows a major trauma. It can follow overwhelming infection and sepsis, OB complications. This is a complication that you will see postpartum. It can happen with cancers, severe burn or crush injuries, and leaking of intestinal contents. So it can happen after a lot of very severe things happen to people, and then this piles on top of it. The other thing that you need to think about is this is bleeding in the absence of the history of another hemorrhagic disorder. So these people don't have thrombocytopenia or hemophilia or anything like that, but they're just all of a sudden are bleeding from everywhere, and that's when you want to suspect DIC. So the diagnosis, of course, would be prolonged bleeding times and increase in fibrin degradation products, which means clots are breaking up, decreased hemoglobin, and elevated D-dimer. Again, a D-dimer, if you recall, has to do with clots that are degrading, decreased clotting factors, and decreased platelets. These are all being used up in the disseminated intravascular coagulation, the clotting part of it. So signs and symptoms: abnormal bleeding. They bleed from everywhere. They bleed from their IV site, they bleed from their Foley site, their NG site, anywhere that they can possibly bleed from, they bleed from. It progresses to bleeding throughout the body, internally. The end is dyspnea, oliguria, seizures, coma, major organ failure, shock, and death. It's always fatal unless it is treated early. So the treatment of DIC involves treating the underlying cause. This just doesn't happen spontaneously. It happens as a result or in reaction to something else. So you want to treat the underlying cause of whatever it is. Supportive care is very important. IVs, fluid support, pressure support, anything else that's needed. You want to be very, very careful when you move these people because they just bleed everywhere. They are, of course, going to get blood products, and the thing that makes this so counterintuitive is they bleed, and what is the treatment? IV heparin. You give them in terms of blood products, you give them FFP because remember, fresh frozen plasma has plasma proteins, and clotting factors are plasma proteins. And so that plasma is very important. They get infusions of platelets, they get vitamin K, and they also get cryoprecipitate, which has clotting factors in it. Nursing management for DIC, be alert to the possibility of this whenever anybody has a predisposing condition. Labor and delivery and postpartum nurses should be alert to this. Anybody who works in the ICU and sees people after a major trauma, people who are septic, that sort of thing. Teaching people when you're discharging them after having a baby, that's very, very important. Early detection of external bleeding is one of the first things that the nurse needs to be aware of is that the bleeding gums when there shouldn't be, the nosebleed when there shouldn't be. Why in the world is that IV site or that venipuncture site oozing? That should not be happening. Pick up on those things and report them and be alert to them. Monitoring changes in vital signs and changes in level of consciousness. Those might be indications of internal bleeding. And then also avoiding any kind of trauma. And that could just be as little as moving somebody or turning somebody, and really taking care not to dislodge those clots once they have formed. So finally, a little case study here. Woman is admitted to the ICU after the difficult delivery of her new baby. What data will you collect as you care for her? Well, of course, you'll be monitoring vital signs. You'll be reporting falling blood pressure, rising heart rate, because that will indicate bleeding. You'll be inspecting her skin, mark bruised areas. Why would you do that? Well, because you want to see if they're expanding. You want to make sure and monitor her urine, stool and vaginal discharge for blood. Now, of course, she's going to be bleeding because she just delivered, but some bleeding, a little bit of bleeding is one thing, profuse bleeding is another thing. Monitoring stool, of course, will include frank blood as well as occult blood. So what treatments do you anticipate? Well, if she has DIC, she's going to get a lot of fluids, and blood products that she will receive can include fresh frozen plasma, platelets, and cryoprecipitate. As an LPN, you would have an assisting role here. You would be active, of course, in supporting care to minimize injury, do ongoing assessments, and monitor level of consciousness. You could help, depending on your facility policy, with the administration of blood products, but again, you need to know where you live, what your scope of practice is, and what your facility policy is, depending on the state you live in. What concerns do you think that the mom will have? Well, for sure, she'll have a concern for the new baby. She'll want to see that baby, but she is going to be really, really sick. So it would be really good if you could arrange visits, if possible, and have some family member there to be able to stay with the baby, and also to bring the baby in to see mom, and make sure mom has that opportunity to bond if possible. So number 4, she's to receive an IV of fresh frozen plasma. You've got 300 mils total going in, and you want that to go over 30 minutes. What is the rate that you're going to set the IV pump for in mils per hour? If you figure that out, that's 600 mils an hour. That's pretty fast. So hopefully you've got either an 18 cage peripheral line in, or maybe at this point, hopefully you've got a central line in. And then the last question, what members of the healthcare team would you anticipate collaborating with? Well, for sure the RN. I mean, this is a situation where you're going to want an RN to be in charge of this person because they're going to be in the ICU. The providers would include not only the obstetrician caring for her, but also the intensivist, because remember, she's in the intensive care unit. You'll have a neonatal nurse, the baby's nurse, who will be responsible for hopefully getting the baby in to do some bonding, and then a social worker, because these people are going to need some ongoing help.